Hello, welcome to this lecture. Today we are going to discuss emphysema, and I'm going to present another case. A 46-year-old man complained of progressive dyspnea and cough. He has been hospitalized multiple times for over the last 2 years for respiratory distress. Bronchoscopy is performed with biopsy of the lung. Histological analysis revealed the large air-space distal. That is one of the key important characteristics, that air-space distal to the terminal bronchiole occur, and then the chest X-ray confirmed the diagnosis of the emphysema. So when we take a look of the objectives, we need to define and classify emphysema, discuss the pathogenesis of emphysema, understand the morphological characteristics of emphysema, discuss the clinical features of emphysema and the conditions related to emphysema. When we talk about the definition, it is the change, or we can say the permanent enlargement of the air space distal to the terminal bronchioles. This is a normal bronchioles where you can see that the alveolar sacs are healthy, they are normal. But what happened in emphysema, they are disoriented, disintented, their septa has been broken down. So that happened to the alveoli collapse, and then it damaged and destruct the walls without signet fibrosis. That is very important, because in the previous disease, there will be the formation of hyaline membrane, but in this case, they will be without fibrosis, emphysema occur. So these are another pictures of normal. On the left side, alveoli and alveolar ducts and alveolar sacs, where on the right side you can see that in emphysematous lungs, the ducts become narrows, and you can see the arrows over there, and then air sacs collapse, and that occur in the emphysema. How can we classify? We classify them into 4 major types. One is centri acinar, second is penna acinar, third is distal acinar, and fourth one is irregular acinar. So we classify them into centri acinar, penna acinar, distal acinar, and irregular acinar. So if you see that, it's the normal acinus that consists of alveolus. This is the alveolar ducts that connected to the alveolus, and left side is the respiratory bronchiole, RB. So what actually is in comparison with the centri acinar and penna acinar. In centri acinar, on the left side we have this section, and this section is showing you the respiratory bronchiole, and they align in the middle of the branch, middle section of the branch. That's why we term them is centri acinar, on the central part. Whereas in penna acinar, it is the emphysema actually usually occur in the distal part of the ducts, or in the alveolus or alveolar ducts. So the anatomical position is important for the classification of different types. When we talk about centri acinar, the emphysema is in the center part of the on the central part on the respiratory bronchiole, whereas in penna acinar it is on the terminal part on the alveolus and alveolar duct. I have to put some more pictures to explain this thing. Again, on the left side is a normal picture, which we know that this is terminal bronchiole, this is respiratory bronchiole 1, then further branch 2 and 3, RB1 and RB2 and RB3. Then we have, this is alveolar ducts, and then we have alveoli. We can say that alveolar sacs. So this is the normal branches that go to the tail. What happened in centri acinar, you can see this swell part, it is in the respiratory bronchiole, and especially in RB2 and RB3, which is the central part of the branch. Whereas in penna acinar, you can see it is more on the terminal sides in alveolar sacs and alveolar ducts. It is more commonly profound, and that is why it occurs at a distal part of the branch. Then another picture to explain the same thing. I just put multiple pictures to explain. Then we have centrilobular emphysemas. Again, this is explaining the central part affected with the emphysema at respiratory bronchiole. The other sections are normal. Whereas in irregular emphysemas, if it is irregular, then it occurs in the all sections. It may be in the respiratory bronchioles, or it could be occur in the septums. So it can be occur in both sections. I can call section A and section B. So it can be occur in both section A and section B. Whereas when we talk about paraseptal emphysema, this is only linked to alveolar ducts and alveolar lights, not on the respiratory bronchiole. So the anatomical position of the emphysema is very important. How can we explain the pathogenesis? The pathogenesis of emphysema is very important because it is caused because of the number of irritants. And what are the irritants? It could be caused because of the, you can say that, smoking. If a person is smoking, because cigarette smoking and inhaled particles are responsible for oxidative stress, we can call reactive oxygen species. And actually these reactive oxygen species also involved for the later on cancer formation, uh, for causing cancer. So the cigarette smoking or inhaled particles is in for important role as an oxidative stress, and they are responsible for causing tissue damage and inflammation. That is the first stage. So if you take a look of that smoking is one of the factor. Then genetic predisposition, sometimes genetic factor is also important, such as, for example, we're talking about the protease and anti-protease imbalance caused because of the congenital alpha-1 antitrypsin deficiency. So the genetic factor of deficiency of alpha-1 antitrypsin is one of the factor for causing the emphysema. Then we mentioned that oxidative stress increase because of the cigarette smoking, because they increase ROS, reactive oxygen species, that is responsible for increasing apoptosis and senescence. Then inflammatory cells will be released. There will be release of the inflammatory mediators. And what are the inflammatory mediators will be released? We can say that the common inflammatory mediators are leukotrienes and tumor necrotic factors, and that attract more chemotactic factors to release more pro-inflammatory cytokinins and then cause death or insult to the alveolar sacs. Then the protease and anti-protease imbalance is caused because several proteases are released from the inflammatory cells and epithelial cells that break down the connective tissues. And in patients who develop emphysema having relatively deficiency of the protective anti-proteases, it means the absence of alpha-1 trypsin, that is very important. And patient that having defect of alpha-1 trypsin, which is responsible for the protective factor, result for the injury to the alveolar sacs. And why this occur? Because of the missing allele, a missing genotype. We are not going to discuss in detail. I mentioned here that alpha-1 antitrypsin, it is a protease-mediated damage of the extracellular matrix that have a role in airway obstruction seen in emphysema. And what happened in the healthy, actually I already mentioned that alpha-1 antitrypsin is protecting the lung from proteases, because proteases is responsible for breaking down the sacs. As please remember this keyword ASE. This is a suffix. If this suffix come, it means break. So proteases. So the suffix this is showing you the presence of the protein breakdown. So the liver actually release alpha-1 antitrypsin into the blood. So because of the genetic malfunction or the missing allele, patients suffer from the disease. And what happened? Deficiency, because of the deficiency of alpha-1 antitrypsin. What is the morphological characteristics? When we take a look of histologic examination, we found a destruction of the alveolar walls without fibrosis, leading to enlarged air spaces. So what is the main thing is that there is no fibrosis. So this is a key characteristic to differentiate the alveolar other causes of the alveolar sac damage. And then the formation of black anthracotic pigment, it means the person is smoker, and if he's smoking, then the black pigment will be found, the fibrosis will be found, the septas, the alveolar walls will be broken down. How can we diagnose? The main thing that diagnose is dyspnea, Chronic bronchitis or chronic asthmatic bronchitis is also one of the features. Then cough, wheezing, whistle-like sound will be found. Weight loss will be appear, and the pulmonary function tests such as forced expiratory volume (FEV) and FVC. These the ratio actually that from the results found that they will be reduced FEV1 with normal or near normal FVC value. So the ratio actually for FEV to FVC ratio is reduced. FEV stands for forced expiratory volume, whereas FVC stands for forced vital capacity. And I know that you already studied in your physiology textbook that why FEV and FVC ratio is important, because FEV and FVC ratio must be normal. If there is a reduce or sometimes in some disease increase of that ratio, then it can cause lung injuries. So the conditions related to emphysemas are further classified as compensatory or obstructive or bullous or mediastinal emphysema. When we take a look of compensatory emphysema, we have the dilation of the residual alveoli in response to the loss of lung substance. And when we talk about obstructive overinflation, as the second example is this one. So when we take a look of the obstructive overinflation, we have overinflated lungs. You can see the lungs are overinflated. You can see the diaphragm is flattened and the lungs are overinflated. You can see their size and their volume is enhanced. And what happened, this is a normal air sac, and if they enhance air sacs, because air sacs become enlarged, then it can rupture the air sacs. It's just like a spring or elastic spring. If you stretch the spring, you can stretch it at certain point, but if you exceed, because if you put much force and you exceed that strength or force, that what happen that it can stretch beyond that limit so that it will not come back. So the air sacs is just like a elastics. It's just like a stretchable thing that can be extended at certain point, but after exceeding that point, because maybe overinflation, maybe the of some reasons we can found that the overinflated lungs, it can lead to the rupture of the air sacs. What is the reason for overinflation? It could be caused because of the tumor or because of the foreign object that causes obstruction, or you can say that causes blockade, and that is responsible for the accumulation of the more air inside or trapping of more air inside, that is responsible. Then next is bullous emphysema with large apical and subpleural bullous. We can see that these epigrowths, these growths are bulb-like appearance. They look like a bulb, a round-shaped structure on the apical part, and that's showing you the presence of bullous emphysemas. And why bullous emphysemas occur? This is another picture. These round projections, we mentioned them type 1 and type 2 or type 3. What is the cause of bullous emphysema? It is usually thought to be caused because of the deficiency of alpha-1 antitrypsin, and it is more congenital or genetic defect that leads to that bullous emphysema. Then we have mediastinal emphysema. And in what is mediastinal emphysema? It is actually caused by the entry of air into the interstitium of the lung, from where it may track the mediastinum and sometimes the subcutaneous tissues. It may occur spontaneously if sudden increase of the intra-alveolar pressure, such as, for example, with vomiting or violent coughing, that can be responsible for alveolar rupture, and that allow the interstitium or the air to dissect into the interstitium. Sometimes it can develop in children with the form of whooping cough. So the main thing is that it occurs because of the sudden cough or spontaneous cough, or the sudden change in pressure that are responsible for the rupturing of alveolar walls. So thank you so much for today's lecture. Hope to see you again.